This is the Asthma and Allergy lecture for Nursing 517-617 by Dr. Lori Gardner of Nicholls State University. The objectives will be to distinguish between pathophysiology of asthma and allergy, discuss the rational drug selection for the treatment of asthma and allergy, describe the monitoring and patient education required for patients with asthma and allergy. This is a brief lecture. Asthma pathophysiology. Asthma is chronic inflammation. Its activation of type 2 humoral pathway leads to airway inflammation. There is airway hyperresponsiveness that causes wheezing, chest tightness, and dyspnea. There is also airflow obstruction with acute bronchoconstriction and airway edema, and it may only be partially reversible. The Global Strategy for Asthma Management and Prevention, GINA, guidelines are for mild intermittent, mild persistent, moderate persistent, and severe persistent. That is how asthma is classed. So the 4 classifications according to GINA is mild intermittent, mild persistent, moderate persistent, and severe persistent. The goals of therapy are to reduce impairment that is caused by asthma. We want to prevent the chronic symptoms, and we'd like to require infrequent use of inhaled short-acting beta agonists. So, maintain a normal or near normal pulmonary function, maintain normal activity levels for the patient, and we want to also meet that patient and family expectations of asthma care. We want to prevent recurrent exacerbations and minimize emergency department visits and hospitalizations. We want to prevent the loss of lung function and provide optimal therapy with minimal adverse drug reactions. Rational drug selection includes quick relief medications, which are the short-acting beta-2 agonists, the short-acting muscarinic antagonists, and the oral corticosteroid bursts. The controller medications are the inhaled corticosteroids and oral corticosteroids, the LABAs, the long-acting muscarinic antagonists, leukotriene receptor agonists, and the monoclonal antibody therapies. So the short-acting would be like albuterol, levobuterol, ipratropium as well. Inhaled corticosteroids suppress inflammation. The LABAs add on to inhaled steroids. That's like the formoterol. The LAMAs are tiotropium. And the leukotriene receptor antagonist, that would be like the montelukast, and the zapirulcast. When we talk about the controller medications, we think about the monoclonal antibody therapies, like the omalizumab, which is an anti-IgE, oral corticosteroids for daily dosing. Use that as a last resort to manage asthma, and then step down slowly to avoid any adrenal insufficiency. Asthma step therapy. Initial drug therapy and changes to the treatment plan over time are accomplished with a step therapy that is 6 steps. Once control is achieved, therapy can be stepped back down. So remember, it's a six-step process, but it can back down with control. If control worsens, therapy can be stepped up. So asthma strategies to reduce unopposed SABA use. The goal is to reduce reliance on the SABA therapy alone as a quick reliever. Use inhaled corticosteroids, the ICS or LABA product for symptom relief instead of SABA for patients over the age of 5. Reduce severe exacerbations, and then use SABA as a quick reliever for patients less than 5 years of age. Smart dosing for asthma. Single maintenance and reliever therapy is called SMART. That would be budesonide and formoterol. It uses an ICS and LABA product containing formoterol as both the controller and quick reliever drug. This provides anti-inflammatory effects. It reduces exacerbations more effectively than the use of ICS LABA with SABA as the rescue medication. Smart dosing cannot be accomplished with LABAs other than formoterol. For asthma with intermittent ICS and SABA therapy, that is for age 12 and older with mild persistent asthma. Step 2 offers 2 options: daily dose ICS with SABA as needed, or a combination as needed, ICS and SABA at the same time. For managing exercise-induced bronchospasm, use the ICS as a regular controller, reducing the exercise-induced bronchospasms. Adequate warm-up prior to exercise. Pre-treatment with either a SABA or an ICS LABA can help prevent EIB. Avoid exercise in areas of high pollution, cold air, or high chlorine levels in indoor pools. Discuss before choosing controller drugs. Preferred treatment is based on symptom control and risk reduction. Patient goals and concerns, the inhaler technique, adherence, and cost. Now, asthma control. Once asthma is controlled, monitor the patient every 1 to 6 months to determine the need for step up or step down in therapy. Before you step up, review the medication adherence, check inhaler technique, and assess for environmental triggers. Have the patient monitor their asthma exacerbations at home. Educate the patient to recognize early symptoms and adjust medications accordingly. Patients using SMART dosing should use the ICS LABA for rescue dosing instead of a SABA. Pediatric patients that are between birth and 4 years old, asthma medications are dosed based on disease symptom severity, not on weight or age. Can use a metered dose inhaler with appropriate spacer device. Medications via nebulizer can be used for both inhaled steroids and SABA therapy. Inhaler form only for step 3 or higher. For older children and adolescents, step therapy for children ages 5 to 11. The overall steps are similar to those for adults. Smart dosing ranges for low, medium, and high dose ICS may be different from that for adults. Children ages 12 and older are grouped with adults regarding asthma medication dosing. For older adults, aging, they have chest wall stiffness, reduced respiratory muscle function. They have a loss of the elastic recoil within their airway remodeling. This increases the severity of their asthma exacerbations. So determine if their symptoms are reversible or not. With the medications for older adults, they do have increased adverse drug reactions. And the interactions with medications taken for chronic medical conditions like beta blockers. So you want to be very careful when prescribing to older adults. For pregnant women, monitor closely for changes in lung function. All medications for managing asthma should be used according to the stepwise approach. The use of ICS, beta 2 antagonists, montelukast, or theophylline is not associated with increased incidence of fetal abnormalities. Patients should be monitoring, and you should monitor for signs and symptoms of asthma. Pulmonary function tests should be monitored 3 to 6 months from start of therapy. Monitor their quality of life, like missed work or school, sleep, or any change in their usual activities. How frequent are their asthma exacerbations? What do their medications look like? And there should be patient-provider communication and patient satisfaction. Optimal outcome is being able to accomplish activities of daily living with minimal asthma symptoms. Refer them to an asthma specialist if needed, especially if they're having difficulty achieving or maintaining control. If immunosuppressive therapy is considered, any adult who requires step 4 therapy or any child who requires step 3 therapy should go to an asthma specialist. Make sure your patient understands the facts about asthma. Make sure they know how to use their inhalers, how to monitor their symptoms, understand the drugs they're taking. They need to know what drugs are a part of their treatment regimen. If there's any adherence issues like cost. And then you can give them internet-based education resources if they have access to the internet. For allergy pathophysiology, immediate hypersensitive reaction or IgE molecules are sensitized to a particular antigen. Future exposure to the antigen, the IgE molecule is cross-linked, leading to degranulation of the mast cell. Mast cells release histamine, leukotrienes, platelet activating factors, and kinins, leading to local and/or systemic reactions. Allergy symptoms like triggers like pollen, mold, dust, pet dander. Some patients are allergic to milk, eggs, wheat, tree nuts, fish, shellfish. Medications, insect stings, other substances like latex, right? And you want to monitor their symptoms, like if it's rhinorrhea, something simple, or life-threatening shock, airway edema, or even death. For monitoring or rationale of drug selection. You want to use, if they have some type of life-threatening allergic reaction, you want to make sure they have an epinephrine auto-injector available. Immunotherapy, increasing amounts of allergens so the patient can tolerate the exposure with fewer symptoms. They may receive subcutaneous injection of allergenic substances, or they may receive oral immunotherapy, a treatment option for food allergies. Asthma is one of the most common chronic respiratory illnesses. GINA, or the Global Initiative for Asthma, has updated the guidelines for asthma management and prevention. Allergies are common, especially in children, and reactions can range from mild respiratory symptoms to life-threatening anaphylaxis. For allergy monitoring, assess the effectiveness of treatment in controlling symptoms and watch for adverse drug reactions from the medications. For children, use injectable epinephrine, adults as well, but for children is dosed according to weight and monitor for weight gain. Allergy testing may be repeated over time. Make sure you educate your patients on reducing exposure to triggers. And that is the end of that quick lecture.